I'm happy to introduce Matteo Müller, who will speak about cytoreductive surgery and HIPEC treatment of peritoneal carcinomatosis, particularly for patients with colorectal metastasis. Thank you, Matteo.
Thank you for the introduction. It's a pleasure to have this talk today about cytoreductive surgery and HIPEC, a very fascinating therapy of peritoneal carcinomatosis. This is a short outline I will talk about today. These are the topics. What is the surgical concept of cytoreductive surgery? What are the results? What are the patient management? Especially on the outcome, I will focus on colorectal cancer, peritoneal carcinomatosis, and then very important topic, who should get CRS HIPEC? What are the patients who qualify for this very demanding procedure? And at the end, I will give you some key messages to take home with. The surgical concept first described nearly 25 years ago by Paul Sugarbaker. He was convinced that the peritoneal carcinomatosis should have a better outcome that many oncologists or surgeons believed in. And he described as first surgeon the concept of cytoreductive surgery with a complete resection of the tumor, of a macroscopic tumor, combined plus hypothermic intraperitoneal chemotherapy, which should lead to eradication of the microscopic tumor cells which are floating intraabdominally and should be eradicated. These are tumor entities, tumor types that qualify or should get CRS HIPEC. So especially here, dark green, you see pseudomyxoma or peritoneal mesothelioma. These are entities where the indication of CRS HIPEC, nearly every patient should get this surgery, but especially in colorectal cancer, you see that these patients should be highly selected. And this is the topic where I will be focusing at the end, or at the outcomes and patient selection. And as you see above, the red HPB tumors or sarcomas nearly never qualify for this procedure. So in our center, this is a publication 2 years ago, you see numbers of especially appendix tumors and adenocarcinoma of the colon together are nearly 70 to 80% of the entities that get CRS HIPEC here, and pseudomyxoma with nearly 20 to 30%, the most entities who get CRS and HIPEC here. Well, now to the technical concept of cytoreductive surgery. So when we begin the surgery with laparotomy, now a question to the residents, does somebody knows what is the first thing you have to do after laparotomy?
You need to quantify the tumor spread with the PCI.
PCI, and do you know more or less how this is quantified or how this works?
Yeah, you have different areas, I think 9 for the peritoneum and 4 for the small bowel, and you have a number between 0 to 3 for each area, and then you add this, and in the end you have the sum.
Perfect. This is the next slide. Here you see the publication of Sugarbaker 22 years ago. There are 9 parts of the abdomen. You see here all the quadrants, and plus 4 of the small intestine. And according to the tumor size of the tumor, you can score it with 0 to 3. Okay, and this gives you a PCI of 0 to 39 in total. Here you see intraoperative photographs of a pseudomyxoma with a very extended PCI of 35. You see the mucous cells and the tumor load over the omentum and peritoneum, and especially the omental cake here. Here in the pelvis, very extended deposits of pseudomyxoma. And this is very important that the peritoneal cancer index is assessed at the beginning of the surgery. Okay? And then, at the end of the surgery, after resection, you have to assess the completeness of your cytoreduction. So everything that you removed, all the tumor that you have removed, you have to score it if there is a visible tumor or not. And there is a CC score from 0 to 3, where you don't see any tumor. This is a CC of 0, and a CC of 3, where you have a residual tumor for over 2.5 centimeters in total. And does anybody know what our goal is, which CC we should address for CRS and HIPEC?
0.
0, exactly. Well, especially for colorectal cancer, peritoneal carcinomatosis, the score you get is 0. But in entities like tumor types like pseudomyxoma or peritoneal mesothelioma, a CCI of 1 is also feasible to do than CRS HIPEC. So post-operatively, post-resection, here is CC score of 0 when you removed all the peritoneum, when you removed the rectum. This is the look to the pelvis, where you say the stapled rectum, the bladder, and all the retroperitoneal vessels, like the iliac artery, after you resected all the peritoneum. Here you see the specimen after resection, and do you know what part of the abdomen has always have to take away and resect it?
The omentum majus.
The omentum majus, exactly. The omentum. You saw before the omentum with the omental cake has high risk of peritoneal carcinomatosis, and when you have to resect, and the omentum has to go as first. After resection comes hyperthermic intraperitoneal chemotherapy, HIPEC. Well, it consists in lavage of the abdomen, irrigation with chemotherapy during 90 minutes or 60 to 90 minutes with a minimal temperature of 42 degrees. Here you see intraoperative photographs with, on the left side you see the pumping machine, which is driven by the cardio technician, and with some special features you don't see in every laparotomy. Special mask, special gloves, cover of the laparotomy, and the suction tube from the air. Okay, why is that? Maybe for our students, you know why we need such careful clothing in the OR?
Because otherwise it might spread.
Well, what spreads?
Or the carcinogenic cells.
The cells. Is it about the cells, you think?
It's dangerous for the operator.
Yeah, but is it about the cells or something else?
It's about the drug.
Exactly, it's about the chemo, okay? Because chemo is very toxic, and the OR personnel and also the nurses after surgery have to wear special gloves, gowns to change dressings or change the drains, because you can get, especially on the hands, high concentrations of oxaliplatin or platin-derived chemotherapy. And when we talk about chemotherapy, choice of chemotherapy, there were some studies in 2014 and 2011, there was one of them, comparing different chemotherapies like mitomycin, oxaliplatin plus minus irinotecan, and the median overall survival was more or less the same, but we have to take in account that not every chemotherapy is has the same toxic results to the patient. Okay, especially irinotecan is known to be very toxic to the patient. So when you choose your chemotherapy, you should you should use that one that has enough good results, but not a toxic result and the toxic complications for the patients afterwards. And why hyperthermia? Well, when you heat up the fluid, it addresses the damage of the cells directly, the tumor cells, okay? It improves also tissue penetration of the chemotherapy, which leads to a higher tissue concentration of the drugs on the surface of the peritoneum. Reduces the intracellular detoxification, especially after you have the platinum-induced DNA adducts, okay, which leads then to cell death of the tumor cells. This is the goal we have to eradicate all the tumor cells that are microscopically intra-abdominally. And the next topic, very important topic, is morbidity versus outcome. And you know, this is a very demanding operation with a high burden for the patient too. It's a very long surgery and the chemo afterwards. There are some things we have to think about morbidity versus outcome. What is the disease-free survival, overall survival? What are the results compared to the high or to a morbidity or mortality we have to take account in this patient? Our numbers show a reoperation rate of 6%, major morbidity of 8%, and the mortality of 2%. This was 3 patients that in this short period until 2013 had lethal outcome with our clinic. The hospitalization about 16 days, so more than 2 weeks after surgery. Here especially we see intestinal complications, we mean perforations, anastomotic leakages or ileus are one of the main complications, but also pulmonary complications like pneumonia, pleural effusion, etc. Afterwards, quality of life, this is a long way. This is why I put this 3, and this is a long way for the patient for recovery. And there's a publication to say 3 to 6 months until they get the same quality of life that they had before surgery. In this time, the patient can suffer from depression, pain, and very important, they can suffer disturbed digestion after surgery, chemo, and we have to take into account that many patients have a colostomy or ileostomy, and this is for the younger, this younger cohort that has serious HIPEC, it can be very demanding. Coming to the outcomes, these are again numbers from our center. In colorectal cancer, peritoneal carcinomatosis, I told you I'm going to focus on this because there are many other tumor types and we can discuss in our own talk. We'll talk about colorectal cancer, peritoneal carcinomatosis, the median overall survival, 40 months compared to studies from France and the Netherlands, from Kuipers and Elias, about 33 to 35 months, and compared to also studies which show peritoneal carcinomatosis treated alone with chemo, which have a median overall survival of about 25 months maximum. Okay. This is a new trial that was presented in 2018 by Quenne and called the PRODIGE-7 trial, an RCT, which addresses the question, what is the value of HIPEC, okay? Or should all patients get HIPEC after cytoreductive surgery? They had 250 patients, which is split to the HIPEC or no HIPEC group. And the interesting thing is, in the total cohort, they didn't see any difference about the overall survival, but when you take out the PCI, there is a group of patients, namely the group with the PCI between 11 and 15, who profit from or get the benefit from CRS and HIPEC together. So this raises more questions than answers, but third, this is surely a thing we have to discuss if every patient should get CRS and HIPEC with a certain peritoneal carcinomatosis. But this is the first trial that is sure. There are others coming who should get the same data and show this. But the most important thing is about selection, patient selection. Who should get CRS and HIPEC? There are negative risk factors, right? First, can you detect everything? Second, what was the response to neoadjuvant treatment? Third, how high is the PCI? How wide is the peritoneal carcinomatosis spread? And fourth, what is the tumor biology? Okay, what is the histology and what is the nodal status of the primary disease? Here we have a study from our center comparing a CC score of 0 with a CC score above 0, meaning with not possible complete resection. And you see that the overall survival is clearly worse in the group above 0, which means there is no role of debulking, and in these patients, if you can't get a CC score of 0, this is again for colorectal cancer, peritoneal carcinomatosis. Second, response to preoperative chemotherapy. This is a study from PASO 4 years ago, published, where you see nicely in the blue line with a complete response to chemotherapy, and a minor or no response, the green line, you see also a major difference in overall survival in patients after CRS HIPEC. Third, peritoneal cancer index. We had this before. This is the spread of the peritoneal carcinomatosis. And here you see the overall, the median overall survival in the groups, especially in PCI below 5, and the group below 15 or over 15, which leads to the message that a PCI over 15 or a 6 and above should not get or not regularly get cytoreductive surgery and HIPEC on plus. Then the fourth, tumor biology. What is the histology of the tumor? Is it a signet cell tumor, or is it a non-signet cell ring tumor? And you see the outcome is much better in the non-signet cell tumor histology. Also very important, what is the mutational status of RAS and RAF status? You see a wild type has a better outcome, even if you take away the patients that got monoclonal antibody therapy before. And as the last one, the tumor biology, the nodal status, comparing N0 or a limited lymph node metastasis to widespread lymph node metastasis of the primary tumor. And all these risk factors, you can take it together and have a risk score, or this is or it would be nice to have a risk score, and this is what our surgical oncology research group did with the bioscope, the bioscore of colorectal peritoneal metastasis, with all these risk factors, taking the PCI, the nodal status, differentiation of the tumor, and the mutational status of the primary. And with according to the points, you can have 4 groups with 4 different overall outcomes. Here, the group A and B with overall cancer-specific survival from 70 months to 50 months, C from 22 to 36, and D up to 16 months with a systemic chemotherapy. And when you apply these groups in our cohort, you see that it has clearly 4 different distinct overall survival outcome of these patients, which leads us to think that the bioscope or a risk score in general is a very good thing to select patients before cytoreductive surgery and HIPEC. Coming to the end, I want to give you some key messages. First, we talked about surgery and chemo alone, but it is clear that the treatment of these patients is a multidisciplinary thing. Okay, we need oncologists, we need maybe a psychiatrist or psych-oncology that talks to the patient, who decides in a center what the patient should get. Second, cytoreductive surgery and HIPEC should be performed in curative intention. Okay, like I said before many times, be as radical as possible. A CC score of 0 is the score you should address, especially for colorectal cancer, peritoneal carcinomatosis. And last but not least, tumor biology is key for patient selection. Okay, so the value of scores is very important to predict prognosis for patients, especially when you think that this have the outcome and the morbidity of these patients in mind. Thank you very much.
Thank you for this nice presentation. I think you showed us nicely that the surgery has and will have a place in the treatment of peritoneal metastasis, but there's still a lot to learn and a lot of research ongoing, particularly also regarding the value of the HIPEC perfusion itself, questions that were raised by Prodigy 7. Do you have questions?
For the score, can you assess this before surgery, or do you need elements which you only can gather during the HIPEC procedure? Because I'm asking the high-risk group D, which was usually these probably you should not do. So if you would have the score perhaps before, you could upfront perhaps stratify to, I mean, avoid surgery or do surgery. And what is the C statistic of this score? I didn't see it, the prediction.
The C score was pretty high, but I don't remember the exact number. I don't memorize that. Regarding your 2 other questions, I think 2 points. Number 1, the score is not a red line. It's just to get an idea and about the tumor biology and how you can manage this patient. But it doesn't mean that with a high score you have a clear contraindication. You just have to be aware that the prognosis may not as good as you wish. And regarding the preoperative assessment, there is one limitation, which is the PCI, and this remains with all imaging modalities, and this is why we often do a diagnostic laparoscopy. And with the large groups, categorical groups, it's pretty convenient to use.
A good proportion of those patients are getting systemic chemotherapy preoperative. And now some surgeons propose to perform a laparoscopy and do upfront PPOP. What is your opinion about this approach?
I think this is even more experimental than anything else. Treating or doing surgery, giving chemotherapy is quite evidence-based, at least from large for chemo from our randomized trials. For surgery, it's at least large databases. PPOC, for PPOC, we have only 17 patients published in the current literature, and that we have to be clear about. It's theoretically a nice idea. Might be that it that it becomes a strategy like that, but it's completely experimental.
The question that I have, or I'm a little bit bothered by the Prodigy 7 study. In essence, it shows that CRS and HIPEC does not have any effect. Now, you have shown good data that that there are subgroups that will benefit from this therapy. And so my questions are, did the Prodigy 7 study show a subgroup analysis of potential patients that will benefit from this therapy? Or the other question would be, are there other studies out there in a similar randomized manner that would show efficacy in the overall patient cohort of colorectal cancer patients?
Thank you. I'm happy you're asking this question. Now, Prodigy 7 was a multi-center study. Most patients were treated in 3 hospitals, and the question that was addressed was not, is CRS HIPEC beneficial, but does the addition of HIPEC to CRS add a benefit? So, and that's also what you see in the control group. CRS radical surgery seems to offer a benefit. 41 months in metastatic patients is quite a good outcome. Now, the surprise was that the addition of HIPEC with oxaliplatin at 43 degrees for 30 minutes did not overall result in a survival benefit. And that's quite a clear and straight result. Now, the question that is open is only, is HIPEC beneficial, not CRS? I think that's an important point to make. Number 2, yes, there was a subgroup analysis, which is not published because the study is not published. It's just out as a ASCO and PSOGI abstract. And it says that a PCI higher than 15 profited from HIPEC. And that's interestingly also the situation with ovarian cancer. There's a randomized trial in the New England showing that advanced extended ovarian cancer seems to profit from the treatment. And that's probably also, that may change, that particularly patients with diffuse disease profit from this additional treatment. That's one of the reasons why prophylactic HIPEC has probably no role anymore. There are a couple of other studies out that go in the same direction, that if you have only minimal disease, it's probably not as beneficial as we think.
Do you think these results will make surgeons move away from HIPEC?
No, it shouldn't, because it's still an experimental procedure, and I mean, compare it to chemotherapy. Just because you have one study which is not so dramatically, doesn't show a dramatic benefit, you don't stop giving chemotherapy. Remember cetuximab, anti-EGFR treatment. The first studies were negative, and it finally ended up with subgroups that now regularly receive this treatment. I think it's not yet a standard treatment. It needs to be further explored. That's the key message.
One question, where are these recurrences? Are these local recurrences? Are these systemic recurrences? Do you see any reason to give adjuvant chemotherapy after the HIPEC? And another short comment is, if you look at this, the recurrence-free survival is 13.1 months for patients with peritoneal metastasis and colorectal cancer. This is pretty much what we see as well in the patients after 2-stage hepatectomies. In your opinion, is it what is more life-limiting, the liver metastasis or the peritoneal metastasis?
There's an interesting ESA abstract out now, not out now, but submitted, which answers exactly this question. It's about half in the peritoneum and about 20% in the liver, and the peritoneum has a major impact on survival. A negative, major impact.
Okay, so thank you so much.
Thank you.
Well done.